We have the first presenter, Dr. Mallika OU, on diabetic retinopathy awareness among healthcare professional students in Kerala.
Good morning. My study is on diabetic retinopathy awareness among healthcare professional students in Kerala. So India has about 74.2 million diabetic patients in 2021, of which it will reach to 129.4 million by 2045. According to International Diabetic Federation, India has the second largest diabetic population in the world. 1 in 6 patients with diabetes have diabetic retinopathy. Currently, 12.5 million people are suffering from diabetic retinopathy. The current rate of blindness due to diabetes is about 7.7%. So in a study by what about Kerala? In a study by Ramesh Hossain et al. Conducted in Kerala in a Chekamanad Panchayat, of which 1,538 people known to have diabetes, only 40.7% had good knowledge about diabetic retinopathy. Only 9.6 had undergone screening for retinopathy, and only 36.4% of our people said that they had some information from their treating doctors. Here is the importance of awareness creation among healthcare professional students who are going to treat the diabetic patients irrespective of their specialty. So why this study? As the first point of contact for a patient is a physician who treats the diabetes, it is their duty to educate the patient regarding diabetic retinopathy. Enough and more studies are there showing the lack of patient education by physician. This study looks at the lacunae in diabetic retinopathy awareness among healthcare professional students. So the objective of the study was to assess the awareness about diabetic retinopathy among the healthcare professional students, and this includes MBBS students, BDS, paramedical, nursing and pharmacy students. A Google form which was properly validated 25-point questionnaire was prepared about the demography of the respondents and awareness about the diabetic retinopathy, and this was circulated online amongst different medical colleges inside the Kerala. A total of 1,205 students responded to the form. 983 were MBBS students, rest were BDS, nursing, pharmacy, paramedical students. 7 students were type 1 diabetic on insulin. 916 students had some relatives or friends as diabetic. We did a subgroup analysis of the students with and without diabetic relatives and awareness of diabetic retinopathy. Generally, all students used to check their eyes only when there was an eye problem, about 66.9%. 20% of 7 checked their eyes annually because they are myopes. 93.9 knew that diabetes can affect the eyes. Regarding the treatment, 38.6 did not know anything. 20.6 thought laser is the treatment. 6.2% thought injection is the treatment, and 22.8 mentioned surgery as the treatment. 23.7% thought an individual with controlled diabetes can avoid regular eye checkups. 26.4 thought treatment can restore the normal eyesight in diabetic retinopathy. 38.8% did not know the answer. 70.4 thought that the diabetic patients are not doing eye examination due to lack of awareness. 10.8% thought it is because of the financial reasons. Only 36.6 knew the simplest and cost-effective method and detection of diabetic retinopathy is dilated fundus examination. 42.9% did not know anything. 11.4% thought the first screening should be only when there is an eye problem. 42%, 7% knew a diabetic with good vision still can have retinopathy. 40.6% did not know. So we did a separate subgroup analysis. 76.6% of the respondents had some friends and relatives as diabetic patients, and that could be a cause for a reasonably good awareness. But there was no significant association in respondents with and without diabetic relatives. So there are so many important literature which shows the lack of awareness and delayed presentation as the cause for blinding complications in diabetic retinopathy, and targeted educational interventions of healthcare providers' knowledge translates into patient education even in slums like Dharavi. Multiple studies support that physician recommendations are strong determinants of patients' adherence to screening guidelines. A study by Rajiv Raman et al. On general practitioners also highlighted the inconsistent knowledge among them regarding the diabetic retinopathy. So to all these points to the need of targeting healthcare providers, we thought it is better to start young. That is why the healthcare professional students are included. Only the exposure of MBBS students during their curriculum was in social and preventive medicine as part of non-communicable disease and in a short ophthalmology posting. Even though the stages and treatment of diabetic retinopathy are taught in curriculum, no much importance is given for the screening protocols. So our study also shows the lacunae in our teaching systems regarding the awareness about the screening for diabetic retinopathy. So what is there in textbooks? The Parsons diseases of the eye, which is considered as the Bible of ophthalmology, mention a single sentence regarding the screening protocol of the diabetic retinopathy. That is, as therapy of retinopathy will at best stabilize the vision or decrease the rate of visual loss, it is important to screen all diabetics annually by examining the fundus after dilating the pupil so as to institute therapy as early as possible. So to conclude, our study shows the importance of including screening for diabetic retinopathy in the curriculum for MBBS and paramedical students. Teaching them at student time itself will make them a better physician and help to bridge the gap of the patient education regarding the diabetic retinopathy. We should remember the theme of World Diabetes Day this year, breaking barriers and bridging the gap. So these are my references. Thank you. Thank you for your kind attention.
I have one question for you. When you gave the questionnaires in the medical students, did you select them, say, third year onwards or everybody?
No, everybody. From first year onwards, I gave.
The first year and second year students are unlikely.
Yeah.
How did you validate the questionnaire?
I took the questionnaire from the previous, from my reference studies, and then majority of the questions were taken by study from Rajiv Raman et al. And
the previous studies were done in India or outside?
Some in India.
And those were done in same population?
No, that is among general practitioners.
So general practitioners, you have taken it for?
Yeah.
How many people did not respond to your questionnaire?
Actually, I gave it to 1,205 responded. I circulated in all the medical colleges. Initially, I circulated among the government medical colleges, and then I didn't get so many responses. Then I asked my friends. I gave the questionnaire to my friends.
What is the main limitation of a questionnaire survey?
Maybe they may not be responding it properly, or somebody may be giving the answer, we don't know.
Thank you, madam.
Thank you.
Next we have Dr. Remya Edacheri. Her topic is on eyes wide open, the keratitis spike in a recent measles outbreak in North Kerala.
Good morning. My paper, Eyes Wide Open, the keratitis spike in a recent measles outbreak in North Kerala. No financial interest. Measles is caused by a virus of paramyxovirus family. It is characterized by fever, cough, coryza and a characteristic maculopapular rash. It's a highly contagious, serious airborne disease that can lead to severe complications and death. And in spite of the availability of an effective vaccine, it still remains a significant global health concern, particularly in regions of suboptimal vaccination coverage. So once it was thought to be under control, but recently it is researched in recent years, posing a significant challenge to the public health system. Primarily, it affects the respiratory and lymphatic tract, but the virus can also disseminate hematogenously, leading to systemic complications affecting various organs and tissues. Notably, the ocular manifestations of measles, less common compared to the respiratory and neurological complications, but can have significant implications for visual health. The involvement of the eye in measles, termed as measles-associated ocular complications, that includes a spectrum of conjunctivitis, keratitis, uveitis and retinitis. Of this particular concern is the keratitis, that is inflammation of the cornea that can lead to visual problem, pain and photophobia. So studying the clinical features and outcomes will help the etiological features in measles. So the pathogenesis of measles includes, in keratitis involves a direct viral invasion of the corneal epithelial cells as well as immune mediated inflammation. So this is a study done in, it's a cross-sectional study, observational study done in patients who were admitted with the clinical features of measles with any symptoms or signs of ocular involvement from October 2023 to February 2024. So we took a detailed history including the general symptoms, ocular symptoms, vaccination history as well as exposure history. Demographic data were recorded. Slit lamp evaluation was done in detail to look for conjunctival and corneal involvement. Fluorescent staining was done in all patients to look for the different staining patterns, and then complete blood count and CRP were sent, and in suspected cases IgM measles antibody were also sent. So this is one of our patient with a characteristic maculopapular rash with conjunctivitis, and these are the different staining patterns. Coming to the results, the maximum number of patients were in the age group of 20 to 40 years, and fever with rashes were present in almost all patients, followed by mouth lesions, cough, sore throat and loose stools. Symptoms, redness was present in 83.3%, followed by foreign body sensation and blurred vision. Ocular signs, congestion in about 71%, though cornea was not clear only in 66.7%, but on FS staining we found that about 74% had one or the other form of corneal staining. So the different staining patterns included superficial punctate epithelial erosions, small punctate dots, large punctate dots and filamentary lesions. So the lab parameters showed a decreased total count with a lymphocytopenia. IgM measles was positive in 3 cases in suspected cases. And these were the treatments given. The systemic evaluation was done by 2 separate physicians. So half of our patients received vitamin A and IV cephalosporin and systemic steroids in selected cases. And the ocular treatment included lubricants, antibiotics and topical steroids. So coming to the discussion, the most recent measles outbreak in India was reported in Maharashtra in 2017, where the children were being the most affected group. But our cohort consisted of immunocompetent adult patients. A 2020 study which reported almost equal involvement in conjunctiva in our studies also almost 70.8%. The rate of keratitis was only 50% in the previous studies, but our study, although 7% had corneal changes, but on slit lamp evaluation about 4% had corneal involvement. So compared to previous studies, there is an increased incidence of keratitis in these cases. And 50% of our patients received vitamin A as a part of their treatment regimen based on the attending physician's preference. But no conclusive evidence from clinical trials to support the efficacy of vitamin A in preventing blindness in measles. And interestingly, 3 of our patients exhibited corneal involvement without concurrent conjunctival inflammation, suggesting that a thorough ocular evaluation should be performed in all measles patients. So limitations include there was a recall bias in vaccination history because most of these patients were in the adult age group, and this was a single Sunday study. So we know that ocular involvement in measles is a well documented, typically manifesting as conjunctivitis or keratitis. But what my study adds, this outbreak underscores the critical need for comprehensive epidemiological and laboratory investigations in suspected measles irrespective of the vaccination status. And the physician usually manages the eye conditions because these patients generally go to the physicians. But the management of keratitis requires particular caution. Initiating steroid treatment without a proper slit lamp evaluation and ongoing monitoring can lead to complications such as corneal thinning and increased intraocular pressure. And it is essential for ophthalmologists to be actively involved in the care of measles patients, even in the absence of overt eye symptoms, to ensure appropriate management and prevent potential complications. So in the future, research is needed to better understand the factors contributing to vaccine failure and the ocular manifestations of measles, especially in adult population. And future research should also explore the relationship between antibody titers and the occurrence of keratitis. So to conclude, there has been a resurgence in measles which was once thought to be under control, thus posing a significant challenge to public health, and despite widespread vaccination, a notable proportion had keratitis, and concurrently a substantial, this had keratitis and necessitating a deeper understanding of this mechanism. Thank you.
Nice study. Your most common ocular sign was cornea not clear in 60% cases.
66% had relatively clear cornea, but on a fluorescent staining, about 71.9% had corneal involvement. There was staining positive. Thank you.
Next presentation is by Dr. Natasha Radhakrishnan. Is there a ROP epidemic? Results from a decade of ROP experience at a tertiary care center in Kerala.
Change on Natasha. Can you move it here also for me?
Good morning to all. My topic is there a ROP epidemic? Results from a decade of ROP experience at a tertiary eye care center in Kerala. So ROP, as you know, is a vasoproliferative disease that affects premature infants and is on a rise in India as a result of the improved neonatal care and better neonatal survival rate. Approximately 2 million babies out of 26 million annual live births in India are born with birth weight less than 2,000 grams and are at risk of developing ROP. What has happened in India in the last decade? This study was designed to understand whether the incidence of ROP has increased over the last decade in spite of great advances in screening, detection, and treatment. So aim of the study was to compare the incidence of ROP any stage and treatment requiring ROP between 2009 to 2013 and 2019 to 2023, 10 years apart, to compare the demographics of premature births screened for ROP, including gestational age and birth weight in this study period. Materials and methods, we conducted a retrospective comparative study of the data from a tertiary care center during the period specified earlier. In our center, babies less than 35 weeks and less than 2,000 grams are routinely screened for ROP. The examination is done by a trained retinal surgeon after dilatation with a mixture of diluted phenylephrine and tropicamide, and treatment requiring ROP was defined as per the ET-ROP criteria. Fundus examined with a binocular indirect ophthalmoscope and 28D condensing lens. Data was entered into the ROP sheet as per ICROP guidelines and scanned into the EMR. The data from these 5 years, 10 years apart, was obtained from the EMR and entered into a proforma for the study. Gestational age, birth weight, risk factors of ROP like hours of oxygen use, ventilation, blood transfusion, anemia, stage of ROP, presence of ROP, treatment details, and regression were also noted. Statistical analysis was done using the SPSS statistics software, and the results are given in mean plus standard deviation for continuous variables and frequency for categorical variables. Pearson chi-square test was used for finding the association between categorical variables, and to test statistically significant difference, independent sample test was applied. We looked at screening and treatment data 2009 to 2013, 2019 to 2023. A decade back, 343 babies were screened, and from 2019 to 2013, 771 babies were screened. Number of subjects screened by time period is shown in this graph. If you look at regressed ROP and treatment requiring ROP between these decades, a decade back, 343 babies screened, of which 58 babies developed ROP, 20 babies, 5.8% developed treatment requiring ROP. After 10 years later, we screened 771 babies, of which 128 babies, 16.6% developed ROP and 6.5% required treatment. There was no statistical significant difference in these two groups. So this shows the distribution. You can see they're almost neck to neck between the two decades. Distribution of gender by time period in subjects who developed ROP, there is some difference between the two with a male and female difference, but it was not significant again. Comparison of birth weight and gestational age. In mean birth weight was found to be 1.08 a decade back. Mean birth weight is 1.5 now. Although the average birth weight is lesser in the current decade, again, it was not statistically significant. A comparison of gestational age, the mean gestational age was 29.36 earlier, and it is 30.36 now. Again, not statistically significant. Now, when did ROP develop over the decades? Again, in the 28 to 35 age group, that is the week when ROP developed, decade back, and it is the same time that ROP developed now also. Distribution of birth weight also, the category that maximum ROP developed was in the 1.5 to 2 kilogram birth weight. So in inference, the number of preterm births are very high, and therefore ROP screenings are more than double of the last decade. The overall incidence of any stage of ROP and treatment requiring ROP remained almost the same. The gestational age group at which maximum incidence of ROP occurred also didn't vary between the 2 decades. There was no statistical significant difference between the 2 sets of data 10 years apart, except in the number of babies that were screened. That is, the number of premature births that have increased. So the main purpose of the study was to compare this, and the percentage of spontaneously regressed ROP and treatment requiring ROP was also compared. And with the number of neonatal NICU increasing, about 700 government special newborn care units are there across India. So India is currently facing an ROP epidemic, and however, there is difference in range, place to place. Inconsistencies of neonatal care have led to large variability in ROP incidence and severity within India, and oxygen delivery and monitoring also varies. A study by Bowie et al. Compared the incidence in a number of countries, and they found that the number of infants screened has progressively increased from 2010 to 2018, and the prevalence of ROP was 38.45%, any stage. Another study in North India got 18.8% of ROP. But in our study, we found that the incidence of ROP was much less in Kerala. This is in our study in both 2009 to 2013 and 2019 to 23, we had only around 5.4% and 6.5%. So even inside India, the challenges due to increasing numbers of premature babies are different from different states. And the increase in number of premature babies that require screening was more than double, which shows that more training of ophthalmologists is required to take up the screening burden. But the treatment requiring has not increased is to some extent reassuring. The reason could be better awareness of the risk factors for ROP among neonatologists, controlled and judicious use of oxygen, and good supportive neonatal care. Our limitation is that although we have kept the screening criteria same, some treatment guidelines and treatment protocols have changed over the last decade, and this is the confounding factor. So in conclusion, there is a definite and significant increase in number of births, but almost similar incidence of ROP, especially the treatment requiring stage. Even then, the increasing numbers means that we should train more and more ophthalmologists to screen for ROP. Thank you. These are my references.
Do you have any data on how many were IVF babies or had assisted fertility issues, or age of the mother? Because
no, ma'am, we have not
number
taken.
of premature babies doubling, you have not looked into any of those factors here.
We routinely screen babies who are coming in from an IVF center also. So both sets of data have those babies, but exact number I have not looked into.
That could be one reason, and of course, very huge payouts by cohorts.
Yes, ma'am.
Very nice study, Natasha. So you have already give a recommendation that we need to increase that number of ophthalmologists who were qualified. Any other recommendation you want to highlight?
Increasing the awareness among neonatologists, because even now there are several pockets where the screening is not happening. So that also is very important.
And
public awareness also, yes. Thank you.
Next, we have Dr. Ladika VK. She is presenting on submacular detachment as a biomarker of therapeutic outcomes in BRVO, a prospective cohort study.
Good morning. My paper is on submacular detachment as a biomarker for therapeutic outcomes in BRVO. Macular edema is the leading cause of impaired vision in BRVO, and submacular detachment contributes a significant proportion of macular edema cases. So it is very relevant for clinicians to know whether SMD impacts the therapeutic outcomes or prognosis. So we have conflicting evidence on this, and that is why the study was designed to assess and compare the therapeutic outcomes following intravitreal ranibizumab in BRVO patient cohorts with CMD and those without CMD. It was a prospective cohort study done in a tertiary care teaching hospital over 18 months on 60 patients who were recruited by consecutive sampling. all patients with BRVO and macular edema who were treatment naive and had a defective vision of less than 2 weeks were included. Patients with coexisting retinal disease and not consenting to participate were excluded. The study population was grouped into cohorts of 30 each with and without SMD, and both underwent intravitreal ranibizumab injections 0.5 milligram, and they were assessed at 2 weeks and 4 weeks following the intervention by the same examiner, and all of them underwent complete ophthalmic evaluation and SDOCT examination. The primary measure of the treatment therapeutic outcomes that we looked at were the BCVA and the CMT reduction, and the secondary measure was the decrease in SMD per se. We also looked at the pattern of therapeutic response, as in which group exhibited a faster response and a more sustainable response. Therapeutic outcomes in each group over time were measured using the pair t-test and the Wilcoxon sign rank test, and the difference between the groups by the independent t-test and the Mann-Whitney U-test, and p less than 0.05 was considered statistically significant. The mean age of our population was around 63 years, and males outnumbered females. All of our patients had hypertension. So coming to the crux of the problem, we found that at the baseline, BCVA was marginally higher in the non-SMD group. Both groups had a statistically significant increase in vision at 1 month and also at 2 weeks. You can see the number of Snellen letter improvements. It was 8 letters in 2 weeks versus 10 letter, 13 letter versus 11 letter. So the highlight is that though both groups improved, there was no statistically significant differences in the BCVA improvement. That means both SMD did not matter actually regarding the final BCVA attained. So but the trend of BCVA improvement over time was different. In the non-SMD group, you can see that in 2 weeks itself, 10 letters improved. Then it sort of plateaued off. That means there was a rapid response and better vision at 2 weeks and almost plateauing thereafter. Whereas in the SMD group, the visual improvement was rather, uniformly distributed over 4 weeks. Going on to the CMT changes, the baseline CMT was higher in the SMD group by around 200 microns, and both groups exhibited significant reduction at 2 weeks and 1 month post-injection. However, if you look at the rebound, both had rebound edema after 2 weeks. If you look at the rebound, you can see that it was more and more statistically significant in the SMD group. So what does it say? It says that there is a more rapid, stronger and sustainable anatomical response in the SMD group with less of a rebound happening. We also looked at SMD reduction per se. So the baseline SMD height was 220 microns. It decreased by 51% at 2 weeks and by 63.5% at 1 month. And most of this resolution occurred in the first 2 weeks, probably reflecting in the CMT decrease also. So these are the images showing this therapeutic response, and many studies concur with our studies in that the eyes with SMD has a better anatomical response and comparable visual outcomes, but there are studies in discordance saying that final BCVA was better in patients without SMD at baseline. Actually, the strength and limitation of the study happens to be the same, that is the short follow-up time. Because of the short follow-up, there was nil attrition of the sample, but naturally we could not follow up all SMDs to their complete resolution. So in conclusion, SMD in BRVO responds well to ranibizumab with peak reduction happening at 2 weeks. SMD is a biomarker for significantly faster, stronger and more sustainable anatomical outcome as measured by CMT reduction, but it is not a biomarker for significantly better visual outcome. Visual outcome was actually slightly better in the SMD group, but it was not statistically significant. The BCVA improvement was more rapid in non-SMD group, while SMD took a little bit more time to reach the same visual outcome. So what is new about this study? This study offers new insights into the influence of SMD on the trend and the response curve, therapeutic response curve of the groups in terms of BCVA and CMT. We have studies focusing on the quantum of improvement, but not how it is improving over time. And the specific effect of IVR on SMD resolution per se, independent of CMT, was also studied in this group. And this, of course, is real life data from our part of the world. So what happens next? Why is the relevance of this study? It's because the presence of SMD need not threaten retinal specialists and clinicians, it does not mean a worse visual outcome, though patients may need to be counseled for a more gradual visual recovery. So this study, if translated to evidence-based medicine, can definitely help clinicians set realistic expectations regarding therapeutic outcomes post-intravitreal ranibizumab in BRVO patients with SMD. These are my references, and thank you all for your kind attention.
Is there anything new for which you decided to do this study, which was not there in literature?
Yes, because the role of SMD was more clear in diabetic patients. In BRVO patients, there were studies saying that patients with SMD had significantly reduced vision compared to those without SMD. There are some reports saying that they have a comparatively good vision in the, so there were conflicts between the reports. So when we see a patient with and without SMD, the clinician is rather confused on actually what to expect regarding a therapeutic response. Is there a difference? That is one thing. And we also did not know how fast the differences in the sustainability and the rapidity of the response was not there in the studies. So I think that adds value.
You said none of them have ocular issues apart from BRVO, isn't it?
Yes.
Yeah, but 100% of them have hypertension.
Yes.
So wouldn't hypertensive retinopathy be a confounding factor?
We excluded those with any other sort of retinopathies.
Okay. And
all other retinopathies.
how much of this would you attribute to, for example, BRVO is a very significant event in the patient's life.
Yes.
So the moment you diagnose that and you say hypertension, how much of the recovery from intravitreal could be attributed to the control of hypertension after the procedure?
Actually, all these patients, we take a fitness before IVR injection also. So they were all undergoing concurrent systemic hypertension control as a part of treatment itself. So I think that's equally important. Yes.
Next presenter is Dr. Jyoti Krishnan. Her paper is on to compare the utilization rate of hospital and voluntary retrieved cornea in an eye bank in Kerala.
Very good morning to everyone. And my study is to compare the utilization rate of hospital and voluntary retrieved cornea in an eye bank in Kerala. So, hospital cornea retrieval program, HCRP focus on hospital-based death, encourages eye donation using a combined method of motivation and grief counseling. And what are the advantages? There is readily available medical history, availability of younger tissue, lesser time spent in cornea retrieval, and cost effectiveness. And voluntary eye donation. Voluntary eye donation is the act of pledging to donate one's eyes after death. So, the Eye Bank Association of Kerala established in Nittival Hospital, Angamali in the year 1970. Even though we started HCRP, voluntary is the whole strength of our eye bank. So, from literature, we found that the better quality tissues are from the HCRP, and most of the studies of 1 year duration. So, we analyzed our data of 4 year and 3 months data to assess our utilization and what are the post-COVID trend in eye donation in Kerala. We have 8 collection centers and around 300 registered volunteers. This is a retrospective record-based study, and duration is from the 2020 January to 2024 March. All the records of the cornea retrieved during the study period were analyzed. We stratified the corneas into HCRP and voluntary, and the following variables are studied, like demography, suitability of the tissue, type of surgery and utilization, and causes for rejection. The data analyzed with the SPSS software and a chi-square test was used to analyze the all categorical variables and all categorical variables expressed as percentages. Results: total 5,081 corneas were assessed. In this, 3,021, 59.4% in voluntary, and 1,880, 37% in HCRP group. The age distribution of donors shows that most of the donors belongs to the age group of 60 to 80. When we compare HCRP and voluntary group, we can see that the most of the younger tissues are from the HCRP group, and we can see that in 41 to 50 years of age, almost double the amount of corneas are collected in HCRP. And a main predominant pattern is seen in HCRP and voluntary group. The table shows total year-wise utilization of the cornea, and we can see that in 2020 and 2021 there is a fall in collection. Even though there is a fall in collection, there is better utilization of the available tissue can be seen, almost 76% and 82.1% of tissue. And these are the comparison of utilization between HCRP and voluntary group. And we can see that there is a more percentage of the tissues are utilized in HCRP group. So after retrieval, we assess the tissue body's suitability for further surgical procedures. In SCRP group, 1576, almost 80% of the corneas are suitable for further transplantation. But meanwhile, the only 60% is not suitable in SCRP group. In voluntary group, almost 42.6%, 1360 corneas are suitable, but 1838, 57.4% tissues are not suitable for surgical transplantation. These are the surgical utilization in HCRP in voluntary. In HCRP, almost 60% of the tissues are utilized for optical transplantation, and that 44% is for penetrating keratoplasty, 17.1 for DSEC, and 7.9 for anterior lamellar keratoplasty, and 30.8% tissues are utilized for therapeutic keratoplasty. While in voluntary group, 28% is utilized for the optical purposes. In this, 24.6% for penetrating keratoplasty, 3.3% for DSEC, and 0.3% for anterior lamellar keratoplasty, and 14.15% is used for therapeutic keratoplasty. So we assess the corneas tissues as wall globe and corneal button, and from the graph we can see that 95.7% of the corneas retrieved in HCRP group as corneal button. Only small percentage is retrieved as wall globe. But in meanwhile in voluntary group, almost 50% of tissues are retrieved as wall globe and corneal button. And in the most of the wall globe in the voluntary group are used for surgical purposes, so research purposes. And what are the reasons for not using a tissue for surgical purposes? We found that there is very old age, foreign body, infiltrate, cancer metastasis, medium color change, and scar suggestive HSV keratitis and serology. And most of the discarded tissues belongs to the voluntary group. And we also assess the expired tissue. And in 2,839 suitable tissue, only 12 tissues are expired, and that is 11 from the HCRP group and 1 from the voluntary group. So my conclusion is, our study is the first ever iBank study from Kerala with a big data analysis and a duration of 4 years and 3 months. And we found that the younger tissues and suitable tissues and transplantation is more in HCRP. So from the slide, we can see that during 2020-2021, when the India and the world suffered from the COVID pandemic, even though the retrieval rate was so low, the available tissues are better utilized, 76% and 82.1%. And that data is compared with the data from the one other state in India, even with the international data. And after COVID, we can see that there is a rising pattern with better utilization and retrieval. So it shows that there is a effective iBanking was done during COVID and still continuing. And when we compare with the studies from the other state iBanking study, we can know that Kerala is a small geographical part of India with a small population. Even though our population is so small, the results are comparable. So one study done by Dr. Narmada Sharma in 2018 in National iBank of India with 40 months of duration, the results are so comparable. So our iBanking rate is, our iBanking system is so effective. So interpretations, we have to reach out to all multi-specialty hospitals and ask them to link with our iBank, and FT communication with the corneal surgeons, and various public awareness program and voluntary appreciation program have to be done. So let your eyes live on. Don't destroy it. Donate it. Thank you.
Your utilization, the lack of utilization you showed, no, the slide is, there's a different scale for VFS and also HCRP.
Yes,
The scale is, one scale is,
Ah.
so if you look at the graph, it looks similar, but actually it should not be. The scale
So,
you have put
the
is,
total number is different, sir.
yeah, so you should
tot-
not represent it like that, because if
Okay.
anybody looks at it,
It's
it
almost
looks like
same. Okay, sir.
so that's a lot of discrepancy. I mean, there's a difference, gross difference, the scale,
Yeah, sir, but the numbers are different. So from the number, it's
not this, the non-utilization. Yeah,
this one. This one.
no, another one.
The tissue they used for surgical, research
That was-
purposes.
So because there's a lot of resources are being, wasted in retrieving those eyes and then not utilizing it.
No, sir.
So
We have to create a
yeah,
public awareness. So
what-
even one person is voluntarily they are willing to donate their eyes, we have to promote.
No, that is true, but that is what is happening. But still, you're not able to utilize it.
Yeah, we can use it for research purposes, sir, like various wet labs, like the PG training, and even for research purposes, we can utilize that. It's not wastage.
Oh.
Thank you, sir.
Next, we have Dr. Ranjini H. Her topic is on burden of ocular abnormalities among children with disabilities in special schools of South India.
Good morning. My paper is on burden of ocular abnormalities among children with various disabilities in special schools of South India. I have no financial interest in the study. So children with disabilities, they constitute a very critical part of our population, and their assessment of vision is often overlooked because the main focus of the parents is on the primary disability. So there is a need for a very timely and comprehensive eye evaluation for this vulnerable group. So aim of our study was to assess the visual function of children with neurodevelopmental disability and to identify preventable and treatable ocular abnormalities. Ours was a descriptive, cross-sectional and interventional study conducted over a duration of 1.5 years from August 2022 to January 2024. Total 216 children from 6 special schools with various neurodevelopmental disability were examined. It is very challenging for the parents to bring these children to an hospital for an eye checkup. So we approached these children through our mobile eye clinic. Our team consisted of an ophthalmologist, optometrist, optometry interns, and caregivers. We took detailed history from the parents or teachers. We took their consent for examining these children. Visual acuity was assessed with the help of Snellen and visual acuity chart, tumbling E or LIA symbols for children who were cooperative and able to respond. And in children who were uncooperative, we assessed their fixation and following behavior by CSM method. All children underwent a detailed anterior and posterior segment examination. Cycloplegic retinoscopy was done in all children. So here is a short clip of our mobile eye clinic. It's a fully equipped bus consisting of all the relative facilities and instruments required for the detailed eye checkup. Coming to the results, the males outnumbered the females in our study. The mean age group of presentation was 17.15 years, means the maximum age of presentation was in the age group of 10 to 20 years. Coming to the distribution of disabilities, the disability with maximum presentation was autism and intellectual disability, followed by speech delay and Down syndrome. The other disabilities which we noted in our study was hearing impairment, cerebral palsy, attention deficit hyperactivity disorder, seizure disorder, and global developmental delay. There was a history of preterm birth in 21.3% of children, and there was statistically significant association between preterm birth and cerebral palsy. Coming to the distribution of ocular disorders, refractive error was the most common presentation, followed by strabismus, optic disc pallor, and cataract. In the strabismus group, exotropia was the most common presentation. We noted hypermetropia to be the most common refractive error in our study. Coming to the distribution across the disabilities, we found that children with Down syndrome has maximum presentation, followed by cerebral palsy. There was a significant statistical association between Down syndrome and hypermetropia. Similarly, myopia was most commonly present in children with autism, followed by speech delay. when we saw the presentation of strabismus, dyspallor, and cataract across the disabilities, we found that the children with cerebral palsy and Down syndrome has more presentation. Also, dyspallor was commonly presented in children with cerebral palsy. Cataracts was seen mostly in children with Down syndrome. When we looked at the association, we found that there was significant association of strabismus in children with autism, hearing impairment, and cerebral palsy. Also, there was significant association of dyspallor in children with cerebral palsy. So we rehabilitated these children with glasses. We advised occlusion for children with embryogenic risk factors, orthoptic exercises for children with convergence weakness, low vision aids was advised, and we referred children to the base hospital requiring surgery. So it has been already documented that children with disabilities are at greater risk for oculovisual disorders as compared to the age-matched control. So there is a need for an efficient ophthalmic screening and evaluation for these children. And why it is important? Because these children are dependent on vision for their personal and educational needs, and especially these children cannot come to the eye hospital for a detailed evaluation. There are various studies done in the past studying these children, but what makes our study unique is our mobile eye clinic and accessibility and affordability of eye care for these children. So if these children can't come to us for a checkup, we went to them and approached them for a detailed eye evaluation. So I would like to conclude by saying that there is a need for a community-based screening, and especially teachers who can be trained for a preliminary eye examination like assessment of visual acuity, so that the risk factors can be screened and there can be a timely rehabilitation for these children. These are my references. Thank you. Ma'am, all the children were having some neurodevelopmental disability, ma'am.
Because it's a known association.
Yes.
I mean, nothing what you have presented is surprising. You just put it. Because all these associations are known associations for many years. If you go to a special school, any part of world, you are going to find something similar. So, what is your take on it except having a mobile van to see that?
What we noticed, ma'am, that these children were not undergoing an eye evaluation. So that was we. Most of them. We had 43% of the population who had refractive errors.
How many already had prescriptions?
Yeah, so there was a combination of them, ma'am. Children were there with glasses, but then many of them were not very compliant with the glasses, or they were not aware of the importance of spectacles.
And demographically, were they different? Were the children from all over South India, or how was it? Like,
Mainly children from Ernakulam, sir.
Usually these centers, they don't have access to eye care, so somebody has to go and visit them. That initiative has to be taken.
Not at times, because there are a lot of, at least in urban areas, they have access to it. Maybe semi-rural areas and rural areas where the need of the hour.
Especially children with cerebral palsy who are not ambulatory. Yes. Okay, thank you.
Next presenter is Dr. Anna Kurian. Her topic is The Rise of Orbital Dyrofilariasis, Insights into its Epidemiology, Diagnosis and Management.
Good afternoon. My paper is on the rise of orbital dyrofilariasis, insights into epidemiology, diagnosis and management. It is an emerging zoonosis transmitted through the bite of mosquitoes. The most common affected ocular site is subconjunctival space, followed by eyelids and orbit. The major species of medical concern are Dirophilia repens and immitis. The prevalence of repens is found to be 7 to 24% in stray dogs in Kerala in studies conducted by veterinary doctors. This is important because it is the most favorable definitive host. When the worm cannot be isolated from the subcutaneous excised mass, species-specific polymerase chain reaction helps. My primary aim was to study the clinical pathological characteristics of patients with a confirmed diagnosis of orbital dyrofilariasis, and secondary aim was to highlight the importance of PCR in confirming the diagnosis. This was a retrospective study done on 39 patients with confirmed case for a study period of 2 years. Patient demographics, treatment approaches, and postoperative outcomes, blood parameters, mainly absolute eosinophil count, were included. All patients underwent orbitotomy and histopathological examination. PCR was done on only 31 specimens, 8 opted out due to financial constraint. Follow-up was done at 2 weeks, 1 month, and 3 months. All patients whose biopsy and or PCR confirmed the diagnosis were included. Patients who did not undergo surgical excision were excluded. Out of the 39 patients, 17 were in the age group of 41 to 60 years with a slight male predominance. In 2022 to April 2023, we saw 36% of our patients. It almost doubled in the second year, 2023 to 2024. The highest incidence of cases were noticed during June to August, the monsoon season. The most common duration of presentation was 3 to 8 weeks, seen in 51%. Only one patient had a disease duration of more than 15 weeks. Only 3 of our patients kept canine and 2 had feline pets. However, most of the patients lived in the vicinity of stray dogs. This is the geographical distribution of our cases. We had most of the patients coming from Thrissur, and maybe whether it has a bigger epidemiological influence, it needs to be studied on a bigger scale. The most common symptom was swelling with pruritus, seen in 16 patients. All of the lesions were in the anterior orbital space, with 13 being in the supraorbital region and 10 being the infraorbital. Coming to the signs, 23 of our patients presented with the presence of a mass alone. 16 patients had minimal inflammation, mainly edema, 5 of which showed skin fixity. The absolute eosinophil count was elevated only in 8 patients. None of our patients were immunosuppressed. All 39 patients underwent orbitotomy, out of which only 16 biopsy specimens showed the presence of a dead or degenerated worm. The presence of the multiple lumina within the mass is also an indicator of dirofilaria infection. This is the cross-section of a nematode with thick cuticle, evenly spaced longitudinal ridges, and a prominent muscle layer. The remaining 23 biopsy specimens showed only fibrocollagenous tissue. Their diagnosis had to be confirmed using PCR, which tested positive for dirofilaria repens. Out of the 16 specimens which had the worm, 2 gave a negative result for both D. repens and immitis. During the first follow-up, 37 patients showed significant improvement with no palpable mass. 2 patients had persistent inflammation, for which 1 patient needed oral steroids. The second patient required intralesional Kenacort injection. Coming to the discussion, the incidence was found to be higher in individuals aged 41 to 60 and during the monsoon season, implicating an influence of vector control. The rising stray dog population in Kerala may be a causative for the increasing risk of dirofilaria infection, as evidenced by the prevalence of microfilaria in stray dogs in Kerala. All had localized masses confined to the anterior orbital region, so surgical excision was highly effective. All the lesions were non-tender, firm, with minimal signs of inflammation. So this is an important differential diagnosis in acute onset mass. The 2 cases which were not on any preoperative steroids or antibiotics developed postoperative inflammation. So maybe a short course of steroids in the preoperative period may play a role in the limitation of postoperative inflammation. There is an alteration in parasitic structures and decomposition of worms, so this causes an ambiguity in diagnosis. Hence, polymerase chain reaction is important in confirming the diagnosis and also understanding more about the disease. The negative PCR in the 2 cases with isolated worms could be due to an insufficient sample, PCR inhibition, or an emerging new genotype. As evidenced by the studies conducted by Pradeep et al. And Kumar et al., they have identified Dirofilaria hongogenesis, which is almost similar to the repens species in both animals and humans in Kerala. The main limitation was this is limited to a small geographical area in the state of Kerala. Only patients who underwent surgical intervention were included. So the study population does not actually represent the entire census of the disease. To conclude, the possibility of an epidemic is probably because of climate change, vector, and host mobility. It is important to spread awareness regarding vector control and eradication of microfilaria in their natural reservoir. In an endemic region like Kerala, dirofilaria is an important differential diagnosis of an orbital swelling. Molecular analysis is important to increase our knowledge of parasite biology and reveal new genotypes. This is my acknowledgement. References. Thank you. This was only for just 2 years, ma'am. I think we are planning to do a multi-institutional if possible, because this is just a very small area in Kerala. So, yep, we,
No,
yep,
the census also you can get. Dilepharesis is
yes,
not
sir.
a unknown.
Yes, sir.
You can get from the census data. What are the non-surgical
Yes, sir.
that you should have that denominator.
But then it won't be confirmed diagnosis. That's the issue. If it's not surgically excised, unless we have done ELISA, or it won't be confirmed.
Next, we have Dr. Chandrakant KS. His paper is on prospective study of 100 eyes with phacolytic glaucoma undergoing phaco with foldable IOL.
Good afternoon, judges and friends. This paper is about prospective study on phacolytic glaucoma, patients undergoing a phaco with foldable IOL. It was a prospective study run on 100 patients who came to a hospital with pain in the eyes and all, and they were found to have glaucoma, phacolytic glaucoma. Aim of the study is to see the visual acuity, post-operative and post-operative complications in 100 eyes with phacolytic glaucoma who underwent phacoemulsification and foldable IOL implantation. The material and methods, you have got the study design, hospital-based prospective study. It was done in a tertiary care eye hospital in South India. 100 eyes with phacolytic glaucoma were studied. This gives a demographic pattern on the patients. Majority of the patients were in the age of 51 to 70 years. Majority of the patients were in the male group. This slide gives the systemic conditions. Hypertension in 68 patients, diabetic in 42 patients, cardiac in 8, neurologic stroke in 4, malignancy 3, bronchial asthma 8 patients, and patients with rheumatoid arthritis 6. This is a checklist of preoperative tests which was done. Vision was tested. Lacrimal duct patency was done. Slit lamp biomarkers was examined to see whether there was subluxation, things and all. A scan here again. There was immersion A scan also done in cases. Then you have got keratometry, the B scan to rule out any posterior segment pathology. IOL power calculation was done with the Barrett 2 universal 2 formula. This gives a preoperative vision. Perception of light and projection of rays, right is in 94 eyes. Perception of light and doubtful projection of rays in 4, and perception of light present, but projection was doubtful in case of 2 eyes. Preoperatively, all the patients underwent antibiotic drops instillation in the form of moxifloxacin. Topical lotoprotein was also applied. Because of the high intraocular pressure, dorzolamide, timolol, azithromycin is a tablet, and all were given IV mannitol depending on the intraocular pressure. Briefing about operative procedure. This was a temporal clear corneal section. Anti-chamber wash was given. Capsulotomy with after staining with the methylene blue dye. Then using viscoelastics and incision of 5.5 to 6 millimeter diameter. Hydrodissection was done. This is a procedure is explained in the video here. This is the case, one of the case. Doing a 2.2 to 2.3 millimeter keratomy incision. Then injection of the dye. You can see that the exudates in the antechamber. After that, it's injected. You do a under viscoelastic. You do a capsular excess. 5.5 to 6 millimeter is attempted. It should be done very carefully because of the loose nucleus inside. Once this is done, a slow hydrodissection is done. Then using this phacoemulsification probe, the direct phaco chop, stop and chop is also done. You can see how the nucleus is loose there inside the capsular bag. You have to be very careful lest you could damage the zonules, leading like to subluxation. This is cracked now. Then it should be very gently done. The last piece is hence removed. Then loose cortex, if any, is removed with the IA probe. Under viscoelastic foldable intraocular lens, single piece inserted into the bag. The haptic is placed within the capsular bag. Viscoelastic is removed, then hydration of the wound. Wound is closed. You can see the centered intraocular lens. These are the results. At the end of 1 month, 42 eyes had best visual corrected acuity of 6/6, 54 had 6/9, 3 had 6/12, and 1 patient had 3/60. At the end of 3 years, 80 eyes had best visual corrected acuity of 6/6, 18 6/9, 1 had 6/24, and 1 had 3/60. This is the same in the form of the graph. After 1 month, as I said, 42 eyes had 6/6, 52 eyes had 6/9. 3 eyes had elevated intraocular pressure treated with timolol and bremonidine, eye drops 2 times a day. 1 eye had visual BC, best corrected visual acuity of 3/60, had glaucomatous optic atrophy. At the end of 3 months, 1 eye developed a pseudophakic bullous keratopathy, which underwent penetrating keratoplasty at the end of 9 months. 3 eyes developed posterior capsular opacification. All 3 underwent yak capsulotomy, and good vision was regained. 6 eyes developed moderate iritis, which was treated with intense steroids. Intraoperative, 1 eye had only dialysis. Capsular bag, tension bag was inserted, and eye was kept in the bag. This is the complications already described. Discussion: challenge faced by phacoemulsification in papicular glaucoma because of the high milky white cortex, highly mobile nucleus, irregular depth of the antechamber, loose capsular bag, and zonular dialysis. In the series of 100 patients, at the end of 1 month, 42 eyes had a best visual correct of 6/6, 54 6/9. Intraoperative complications were at a minimal. 1 eye had pseudophakic bullous keratopathy, 3 had posterior capsular opacification at the end of the 2 years. Conclusion: phacoemulsification phacolytic glaucoma eyes can be surgically managed by meticulous preoperative management and expert surgical handling. These are my references. Thank you.
Thank you, sir. Thank you for showing the beautiful video also. I think in the whole conference there are only a handful of people who can do this.
Thanks for that.
Yes, sir. I think and the courage to do this should come first rather than be courageous afterwards. So I think it's very nice to see the study. Thank you, sir.
Welcome. Any more questions? Thanks.
Next presenter is Dr. Kiran Chandran. His paper is on characterizing right angle vessel to study its role in mactal progression using multimodal imaging.
Good afternoon. Today I'll be talking on characterizing right angle vessels to study its role in mactal progression using multimodal imaging. So right angle vessels have been defined as per the Gasson-Bloody clinical staging into stage 3 mactal. Recently, a lot of interest has gone into using multimodal imaging, specifically OCTA, in characterizing the vascular changes in mactal. And Saradis and colleagues published a paper in BJO in 2021 where they studied characteristics of RAV in mactal and its relevance with mactal-associated neovascularization. So they studied RAVs as early as in stages 1 and 2 and associated disease progression associated with RAV. And even morphological changes in RAV precede neovascularization in the form of dilatation, elongation, and apparent discontinuation of the vessels and occurrence of pigment plugs. So RAV is defined clinically as per the Gasson-Bloody staging as follows. They appear as vessels with a dilated and more prominent appearance, and which bends at a sharp right angle into the deeper retinal layers. So the quadrant-wise classification of RAV was done by placing an ETDRS grid into the center of the fovea and dividing it into 8 broad divisions using ETDRS subfields. So aim of our study was to determine RAV associated changes on SD, OCT and OCT angiography, and to follow up cases of RAV to determine its role in disease progression, as well as to study RAV associated morphological changes during the disease course. This was a single center observational study recruiting 56 eyes of 49 patients with RAV detected clinically and confirmed on multimodal imaging. So in this diagram, you can see vessels which appear as an RIV, but they are not very definitive. So using a reference standard, that is whole retina slab of the octa, which is an amalgamation of different slabs of an octa, you can see an RIV which is demonstrated very well on a whole retina slab, which may be missed clinically. So using multimodal imaging is important in diagnosing the presence of RIV. So the following parameters were studied using OCT, that is outer retinal defects in the form of attenuation, where there is no obvious loss of any layers, but there is patchy loss. Then coming to loss of IDZ and EZ and loss of external limiting membrane. Then collapse of the inner into outer retina, inner and outer retinal cavitations, pigment migration, outer retinal hyperreflectivity. On octa, we studied the different plexuses like superficial vascular complex and deep capillary plexus are studied for the presence of telangiectasias as well as foveal avascular zone changes. In the outer retina choriocapillary layers, the presence of nodular hyperreflectivity networks as well as retinal choroidal anastomosis was studied for. So 49 eyes of 56 patients, 56 eyes of 49 patients were recruited, and at least 3 follow-up visits were done with a mean follow-up duration of 20 to 52 months, and majority of eyes had stage 3 disease followed by stage 4 and stage 5. So as you can see in this table, majority of the OCT findings had a direct correlation to the presence of RAV. All outer retinal changes ranging from IDZ, EZ and external limiting membrane had an associated RAV to it. Followed by retinal pigment epithelial migration as well as outer retinal hyperreflectivity. So the most common associated RAV finding was with IDZ loss as well as EZ loss. Even in follow-up parameters, at each quadrant where the RAV was present, there was progressive increase in the extent of loss of IDZ, EZ and ELM as demonstrated in this table. In octa, RAV demonstrated telangiectasias in the DCP in all patients, and telangiectasias were typically located in the temporal quadrants in octa, and vascular invasion involving the foveal vascular zone was seen in 4 and 6 eyes in SVC and DCP respectively. The presence of nodular hyperreflectivity, network and RCA was seen in 4, 6 and 3 eyes respectively. So coming to a few examples, this diagram demonstrates the RAV associated interdigitation zone progression in MACTIL. On multicolor photo, you can see the presence of RAV temporally. On whole retina slab of octa, this RAV is appearing very prominent, and corresponding deep capillary plexus shows telangiectasias which appear as slightly dilated and irregular vessels adjacent to the foveal vascular zone. At presentation, the OCT does not show much IDZ changes. This is called IDZ at risk, which appears as a serrated appearance of IDZ. And on follow-up 1 and follow-up 2, you can see the IDZ is attenuated, followed by complete loss of the IDZ at the final year follow-up. This is an example which shows a detailed 10-year follow-up showing RAV associated changes in MACTIL using fundus autofluorescence and OCT. At the initial visit, there is no changes on OCT, it appears normal. When the RAV appears, there is IDZ loss happening with subsequent increase in the EZ loss and pigmentation, which initially is non-central, which progresses to involve central fovea as well. So over here you can see a blue reflectance image showing an RAV superior-temporally, and exactly where the RAV is dipping into the deeper retinal layers, you can see the outer retina shows changes in the form of outer retinal hyperreflectivity with ellipsoid zone loss. As we progress into the disease stage over subsequent follow-ups, you can see the EZ loss is increasing and outer retinal hyperreflectivity is also increasing. And the corresponding octa slabs in subsequent follow-up visits shows increase in the nodular hyperreflectivity to form what appears as an irregular reflectivity, but almost looks like a network forming. So this example demonstrates the formation of retinal choroidal anastomosis in MACTIL. Over here, there's a choroidal neovascular membrane, subretinal neovascular membrane in multicolor photo, and SD-OCT shows the presence of outer retinal hyperreflectivity. The corresponding whole retina slab shows the presence of 2 right angle vessels with a anastomotic complex being formed with the underlying choriocapillaries. On outer retina choriocapillary slab, you can demonstrate the presence of a well-defined circular network. Even morphological changes in the form of vessel straightening, as you can see in whole retina slab, is demonstrated over a 4-year follow-up, with subsequent DCP showing lateral elongation of the foveal avascular zone as the disease progresses, and outer retina choriocapillary shows the formation of a well-defined vascular prominence as we progress towards the disease course. This example again demonstrates using a fundus autofluorescence that the right angle vessel, which was initially dipping inferiorly, shows a sharp deflection as a right angle towards a neovascular lesion, and corresponding OCT shows the presence of outer retinal hyperreflectivity and increase in the ellipsoid zone loss. So what was known before was that RAV was associated with disease progression and contributed to the development of neovascularization in MACTIL, but this study adds earliest changes in the outer retinal layers are directly linked to RAV, and even telangiectasis formation on octa are related to the formation of RAV. So RAV is associated with progressive increase in the loss of all outer retinal bands, and thereby suggesting that RAV can serve as an important biomarker in MACTIL right from the early stages of disease. Thank you.
Very nice study. So my question is that, do you think that those who are not having the octa, they won't be able to pick up all these things, and or in other way, is it mandatory to do octa in all such patients?
So RAV was initially diagnosed clinically, but recent multimodal imaging, especially blue reflectance imaging and multicolor photo, are also extremely sensitive in picking up an RAV, especially the green reflectance as well as the blue reflectance lab. And even FFA was initially the gold standard for diagnosing the RAV, but FFA changes get obscured once the leakage etc. happens. So octa is being employed because it's easy to do an octa and you don't miss out on subtle findings such as an RAV in following up patients.
There is no doubt about the role of octa because it's already known.
True.
So what I'm trying to say is those who are not having access to octa, so how they should, what is your recommendation?
An OCT can be done, and so for example, these biomarkers which I suggested in progressing, showing the follow-up of MACTIL, they can be followed up. And even a cursory examination, we may miss out an RAV. So you can keep a close watch on the morphological changes that develop an RAV. Even a subtle fundus autofluorescence can help actually in picking up an RAV. Yeah.
What about a simple fundus photograph with the high zoom?
Yeah, the 30-degree view definitely helps, and the recent photo I showed where they are. That is a 30-degree. Yes, sir. You can use the fundus photo with 30-degree view where you can pick up RAVs. True. Yes, sir. Sure. Thank you, sir.
Next, we have Dr. Nayana G. Her paper is on understanding strabismus and amblyopia in preterm children, its types and contributing factors.
A very good afternoon to one and all. I'll be presenting my study on understanding strabismus and amblyopia in preterm children, types and contributing factors. So, strabismus and amblyopia can be the common vision disorders that can have a significant impact on the life of preterm children. So, the previous studies has shown the prevalence of strabismus in preterm to be around 20 to 40%, while in term it was around 2 to 5%. And similarly, the prevalence of amblyopia was found to be around 10 to 15% in the preterm, while it was around 1 to 3% in the full term. So, our study was to study the types of strabismus and amblyopia in the children born preterm, now in the school-going age group, and to analyze the factors contributing to the development of squint, refractive errors and amblyopia in these children. It was a retrospective study including 152 children, now in the age group of 5 to 9 years who were born preterm. We have included children born less than 37 weeks, now in the age group of 5 to 9 years, presented to our pediatric ophthalmology clinic, and a complete medical record was available for review. We have excluded children with any history of ocular trauma or surgery. Any congenital anomalies like cataract or glaucoma were excluded. The factors we considered included factors associated with birth history like gestational age, birth weight and NICU stay, postnatal factors like developmental delay or associated systemic conditions, especially neurological conditions, and the ROP related factors like presence or absence of ROP, stage and the treatment taken for that. A detailed anterior segment evaluation was done, followed by an orthoptic evaluation, vision and cycloplegic refraction, and a posterior segment evaluation was done in all those cases. and the type of strabismus, refractive errors, and amblyopia was analyzed. The association of each of those factors with the development of squint and amblyopia was assessed with chi-square test, and the mean age of development of squint was also assessed. Coming to the results, among the 152 children aged between 5 to 9 years, the male is to female ratio was 1:1.2. Majority of the children came in the late preterm group between 32 to 36 weeks, and the birth weight majority came in the low birth weight group. And history of ROP was present in about 37.1% of the study population. The prevalence of strabismus was found to be 52.8%, among which intermittent exotropia was found to be the most common type, followed by accommodative esotropia. Amblyopia was present in 34.8% of the study population. Ametropic and anisometropic were found to be the commonest types. And coming to the refractive errors, astigmatism was the most common, followed by a combination of myopia and astigmatism and myopia. So we did a chi-square test and found the association of each of the factors, and the development of strabismus was having a positive correlation with a p-value of less than 0.05 with gestational age, birth weight, the presence or absence of ROP, the associated developmental delay, and associated systemic conditions. So amblyopia was found to be a significantly high in cases with severe ROP and also in cases which were treated with laser and intravitreal injections. There was no significant association between the severity or treatment taken for ROP and the occurrence of strabismus. And myopia was found to be significantly higher in the laser treated ROP cases. And we found esotropia to be more common in the early preterm, while intermittent exotropia was more common in the late preterms. The mean age of onset of strabismus was found to be 2.76, and for our surprise, about 38% of the cases, the onset of squint was before 1 year of age. About 28% of the cases, the parents noted squinting before 6 months of age. So to conclude, a significant association between gestational age, birth weight, presence of ROP and the prevalence of strabismus and amblyopia highlights the need for regular eye examination in the preterm children with these risk factors. The study's finding on the types of strabismus with esotropia more common in early preterm and intermittent exotropia in the late preterm can be used for targeted interventions. And considering the age of onset of strabismus, a regular orthoptic evaluation along with the cycloplegic refraction is recommended in these children in the preschool age group. So what is already known? According to Vijayalakshmi et al., the existing guideline says if there is no ROP, the first examination should be done at 2 years. If the ROP, if it is not treated with laser, at 1 year the first examination and annually thereafter. If the ROP case was treated with laser, first examination at 3 months and every 3 to 4 months thereafter. So according to this guidelines, many of the times we are getting children at 4 year or 5 years. They may be adding extra years from their this thing also. So what we propose a new guideline. If there is any strabismus or nystagmus, the consultation should be immediate. If the child is not responding to lighter phases or if there is any features of CVI, immediate consultation should be done. And if the gestational age is less than 32 weeks, very low birth weight, history of developmental delay or ROP if not treated with laser also, the first consultation should be done at 6 months. And in cases of ROP cases treated with laser, first consultation at 3 months. So instead of telling the children for a pediatric opinion at 1 year or 2 year, it is better to educate the parents about the warning signs of amblyopia, strabismus and all beforehand so that they can have a earlier consultation before the amblyopia or strabismus or the suppression sets in, and we can help these children. These are my references. Thank you.
Did you include all the ROPs which were examined in your, or did you have any exclusions?
Any cases which was, any surgeries or any cases with any congenital anomalies were excluded, ma'am. And also those children who are not in the follow-up or who are not having the complete medical records, we have excluded, ma'am.
Just from what your record looks like, then most of them at the most received only laser.
Intravitreal also, ma'am.
But I don't think more severe ROPs were included in this, who needed surgery or who were...
Yes, ma'am. If they are presenting to, this was done in the pediatric ophthalmology clinic. So,
So I think you should
yes, ma'am.
mention that. I mean,
Yes, ma'am.
those patients who are opaque, who have had lens weight, who have
Yes,
had
ma'am.
buccal are also coming to your
Yes,
clinic.
ma'am. Yes, yes, yes,
So
ma'am.
you should mention that in our exclusions.
Yes, ma'am.
You have taken you have really
Yeah.
excluded the all severe ROPs from there, right?
Yes, ma'am.
So I think that should be clearly mentioned.
Yes,
You have
ma'am.
excluded patients who could not be recorded vision because of CVI. You have
Mm.
excluded a whole lot of patients.
Yes, ma'am. No.
Yeah, so I think in your exclusions you should mention that. If
Yeah.
you have included only up to laser, who could be?
I have
There is
included
a
like
whole
any.
lot of selection bias in this paper.
Yes, ma'am. I have included in the exclusion criteria. I have mentioned any ocular surgeries, ma'am. So I have considered up to lasers and intravitreal. All surgeries were excluded. Thank you.
Next, we have Dr. Namita VJ. Her paper is on From In to Out, What Causes Consecutive Exotropia?
Good morning all. My presentation is on From In to Out, What Causes Consecutive Exotropia. There's no financial interest in the study. Consecutive exotropia is a manifest outward deviation developing in a formerly esotropic patient after surgical treatment for esotropia. By convention, exodeviation more than or equal to 16% diopter for distance and near is considered significant enough to intervene in case of consecutive exotropia. Based on the onset, it's divided into immediate and delayed. Immediate mainly because of a slip muscle, slip medium rectus muscle or improper suturing, and delayed cases are mainly because of stretch scar or because of late muscle slippage or because of sensory exotropia due to poor vision, amblyopia or suppression. A thorough history looking to the onset of initial squint and the primary surgery parameters along with going through the old photograms and previous discharge summary will help us in planning a proper intervention. So our aim is to evaluate the clinical features and factors responsible for the onset of consecutive exotropia in patients who underwent surgical correction for esotropia. So it's a retrospective EMR analysis for all the patients present to the pediatric ophthalmology center in a tertiary eye care center with the diagnosis of consecutive exotropia from the period 2013 to 2024. The previous surgery data is obtained from a discharge summary, serial photographs, and from the EMR. All patients underwent a detailed ophthalmic evaluation including binocular vision status, cycloplegic retinoscopy, anterior segmented dilated fundus examination, and these were the parameters we assess in case of primary surgery like age at the surgery, type of initial squint, angle of deviation, and the amount of medial rectus recession, and the type of surgery, whether unilateral procedure or bilateral medial rectus recession was done. In consecutive exotropia, we assess the presence of amblyopia, any presence of adduction limitation, any convergence insufficiency, any presence of pattern deviation, inferior oblique overaction, DVD. Also, we assess the position of medial rectus intraoperatively, whether there is any slip muscle or any stretch scar or all the muscle were at the intended position. And all the patient underwent exploration of medial rectus, and most of them underwent medial rectus advancement plus or minus lateral rectus recession. And those with oblique overaction, we did an inferior oblique weakening also. And those with less than 20% diopter, we advanced only one medial rectus. Those with more than or equal to more than 20 to 25, we advance either both eye medial rectus or with unilateral medial rectus advancement plus ipsilateral lateral rectus weakening. Coming to the result, most of our patients were in the age group of 10 to 20 years. The mean age was 18.10 years. Females outnumbered in our study. Coming to the primary surgery parameters, 20 out of 29 patients had primary surgery elsewhere. The mean age at initial surgery was 3.77 years. Most of them had undergone surgery for infantile esotropia. 13 out of 29 patients have preoperative angle of deviation available, of which the mean angle of deviation was 40% diopter and average MR recession was 5.41 millimeter. And majority are undergone bimedial recession than unilateral recess resect procedure. 41% had poor follow-up. Coming to the consecutive exotropia parameters, the duration of exotropia as obtained from the parents was ranged from, the mean was 8.77 years, and the duration between the primary surgery to the consecutive exotropia was 12.91 years. The mean angle of exotropia for distance and near was almost similar. We also assessed the non-surgical parameter and the surgical parameter, which would have led to the consecutive exotropia. In non-surgical parameter, 62 patients were amblio, 82 were suppressed. In refractory status, most of them were emmetro, followed by myope and hypermetropia. 20% had anisometropia, 17% had DVD, and patent strabismus with inferior oblique overaction was present in 31%. Coming to the surgical parameters which would have led to consecutive exotropia, we have found most of them underwent a large MR recession more than 5 with an average of 5.41, and 13.79% had convergence insufficiency, 10.34% had adduction limitation, 10.34% had slip muscle, and we found that medial rectus at intraoperatively, 3 patients had slip muscle, 1 patient had a stretch scar, and rest all had a medial rectus at indented position. All the patients had underwent exploration of medial rectus, and 51.72 patients had underwent unilateral medial rectus advancement with ipsilateral lateral rectus weakening. Coming to the binocular status, 82.75% were suppressed before surgery, of which 65.5% remained suppressed even after surgery. 6 patients attained fusion. 1 patient had a transient diplopia which almost settled by 3 months. Coming to the discussion, the incidence of consecutive exotropia after ET surgery is reported to be 4 to 27% in previous study. The main risk factors for consecutive exotropia we encountered in our study are poor follow-up. It's seen in our study the mean duration of exotropia and the duration between primary and second surgeries were more than 8 years. And once the alignment is done, most of the parents forget about the frequent follow-up, and once an outdrift comes, they will come to the clinic. We also found there was large medial rectus recession in our case series, and the previous studies done by other et al, like it was more than 6 mm of medial rectus recession as the causative factor for consecutive exotropia. However, we found that even at more than 5 mm, there is high risk of consecutive exotropia. So to limit the medial rectus recession by 5 mm, and development of amblyopia is another strong factor which was seen in the other studies also, as the amblyopic eye always has a tendency to outdrift. We also found that adduction limitation, which in turn can lead to a convergence insufficiency, instability of alignment, and can lead to a late exodrift. In case of missed oblique overaction or in pattern deviation, mainly in children with esotropia are examined in the primary position with a modified Krimsky test, and all the oblique overaction are measured in the vertical, in the up gaze or in the down gaze, and in such cases the pattern deviation are usually missed, and an oblique as such is an abductor, and overaction of obliques can lead to an outdrift. DVD also, because amblyopia with poor binocularity can lead to DVD, and DVD is characterized an outdrift, updrift, and extortion, which itself can lead to consecutive exotropia. The other factors are development of new refractive error and late scar remodeling. To conclude, poor follow-up, amblyopia, and large medial rectus recession more than 5 mm is a risk factor. Inferior oblique overaction, DVD, and inadequate refractive correction can also contribute for overcorrection. So all patients undergoing esotropia surgery should undergo a periodic follow-up with proper refractive correction and amblyopia treatment to prevent the development of consecutive exotropia. Limitation data collection due to a retrospective nature and a short sample size are a limitation. These are my references. Thank you.
There were 2 patients who were more than 50 years old.
Yes, ma'am.
So, what was the cause in them?
One patient presented to us at 64 years, and she had history of an acute onset ET. That from the records it was available by 12 years she had undergone surgery, but she presented to us late. Ignored. She was suppressed in that eye. Strabismic amblyopia was there in that eye. And the same patient had a slipped medial rectus also, ma'am.
I think 5 mm is a bit drastic to say, because 6 and more, you can say that, but 5, looking at your data, since your muscles had not slipped.
Only 3 patients have slipped muscle.
Yeah, so I can't blame that 5 millimeter medial rectus recession as your cause. Maybe amblyopia. Was there any correlation did you find with the visual acuity to consecutive exotropia? What was the mean visual acuity in patients who had
Visual acuity as such, I didn't check my. The amblyopia factors I checked that 62% were amblyope.
means how will you say amblyop without checking the visual acuity?
And visual acuity we recorded, but into consideration.
So, drips are very common if patients have correlation. I think
Next presenter is Dr. Neenat Jose, ocular trauma in pediatric age group, predictive accuracy, pediatric penetrating ocular trauma score.
Good afternoon, everyone. The title of my study is Ocular Trauma in Pediatric Age Group, Assessing the Predictive Accuracy of Pediatric Penetrating Ocular Trauma Score. 20 to 50% of ocular injuries presenting to hospitals occur in children. In children, delay in presentation, unclear mechanisms of injury, and poor cooperation with eye examination can make the initial assessment less accurate. Thus, a precise visual prognosis is a challenge in pediatric cases, and long-term recovery can be complicated by amblyopia. The ocular trauma score was put forward by the Ocular Trauma Classification Group in the year 2002. They also put forward a probability index. Using this probability index, the clinician could accurately prognosticate the final visual outcome with 77% accuracy. According to this prognosing system, the initial presenting visual acuity is regarded as the most important parameter that aids in the prognosis of the final visual outcome, and globe rupture, endophthalmitis, perforating injury, retinal detachment, presence or absence of RAPD are other parameters. But in children, as we know, it is often difficult to assess the initial presenting visual acuity and RAPD. Hence, in 2011, another prognostic system was developed by Ekar et al., known as the Pediatric Penetrating Ocular Trauma Score. According to this system, the initial presenting visual acuity is given less points, and in case the initial visual acuity is not available, the formula 2 into H plus zone minus the corresponding pathology is used to instead of the score for initial visual acuity. The age of the patient is taken into consideration, wound location and concomitant eye pathologies are taken into consideration. The aim of our study was to evaluate the predictive value of pediatric penetrating ocular trauma score and the final visual outcome in children with open globe injury. The secondary objective was to compare the correlation of OTS and POTS on the final visual outcome. It was a retrospective observational study done on 36 patients. The records of children aged less than 15 years who presented with penetrating eye injury from January 2022 to June 2023 were analyzed. All patients were reviewed on the basis of age, gender, time of injury, mechanism of injury, time of admission, time of surgery, type of penetrating injury, initial visual acuity, final visual acuity, and concomitant eye pathology. OTS and POTS were calculated for each of these patients. In our study, around 50% of patients were less than 5 years old, 41.7 were 5 to 10 years old, and 8.3% were above 10 years old. In our study, we could find a slight male preponderance. 70% of the patients were males. Both eyes, right eye and left eye, were found to be equally affected. Most common cause of injury was with sharp metal objects. Complications like iris prolapse, hyphema, traumatic cataract were found to be common. Most patients received surgery within 48 hours of the injury. Complications like vitreous hemorrhage, retinal detachment, and endophthalmitis were found to be rare complications. The initial visual acuity, as expected, could not be assessed in around 52% of the patients, and final visual acuity ranged between 0 to 0.2 logma units in 47.2% of the patients. And upon analysis, we found that POTS correlates well with the final visual acuity, whereas OTS did not show any correlation. Our population of the pediatric globe trauma were similar to other reports with a slight male preponderance. Our study supports the hypothesis that POTS may be superior to OTS in pediatric population in terms of predicting the final visual outcomes. Studies conducted by Aviri et al. And Zui et al. Also support the same hypothesis. A larger study conducted by Shah et al. In 124 patients stated that POTS was found to be more suitable for low-risk injuries and has low predictability in high-risk trauma cases, and that OTS is better in high-risk cases. Conversely, another study by Chowdhury et al. Found that OTS is a reliable predictor of final visual outcome both in blunt and penetrating injuries, and POTS shows gross underestimation of the final visual outcome. Our study had many limitations: small sample size, short follow-up duration, inability to formulate a probability index, difficulty in actual quantification of presenting and final visual acuity in pre-verbal children. All these were limitations of our study. So in conclusion, POTS can be a reliable prognostic tool which can aid in a better communication of prognosis. OTS was not found to be a reliable predictor of the final visual outcome. Our study is limited in many ways. Hence, a large-scale multi-institutional study into the use of pediatric ocular trauma scoring system is necessary. These are my references. Thank you.
I think all the questions we wanted to ask you are put in the limitations. Thank you. Okay.
Thank you.
You cannot conclude if you are not able to check vision for half the whole and half the patients.
Limitation. Thank you.
Thank you.
Next, we have Dr. Marian Poli. Her paper is on outcomes of the surgical management of Sankaramenon palpebrarum.
Good morning, judges. My paper is on the outcome of surgical management of Sankaramenon palpebrarum. No financial disclosure. So as we know, Sankaramenon is a cutaneous xanthoma due to the deposition of cholesterol-laden histiocytes in the middle and superficial layers of the dermis. It is associated with hyperlipidemia in around 50% of cases, and the indication for surgery is mainly aesthetic. Various treatment options are available like surgery, lasers and chemical peels, but each has its own merits and drawbacks. So in this context, we did a study to analyze the outcome of surgical excision in patients presenting with Sankaramenon. It was a retrospective interventional study over a period of 6 years in a tertiary care center. Diagnosis was done based on clinical examination. Histopathological confirmation was done in all the cases. Detailed systemic history was done, and lipid profile was also checked. And if the lipid profile is deranged, physician consultation was done. So the Sankaramenon was graded as per Lee et al., where the grade 1 shows only the upper lid lesions, grade 2 has extension to the medial canthus, grade 3 involves upper lid and lower eyelid, and the grade 4 it was extending to the lateral aspect of the lower lid also. So coming to surgical technique, after local anesthesia, the incision were marked and the skin incision was done with number 15 blade or scissors. Then the lesion is excised with the help of radiofrequency cautery, and the wound is closed in 2 layers with the 6-0 vicryl and 7-0 vicryl. After the surgery, steri-strip dressing was done, which gives strength to the wound. Patients were discharged on the same day and followed up at 1 week, 1 month and then yearly thereafter. For the grade 4, anti-scar creams were started at 1 week follow-up. Patients were evaluated for scarring and pigmentary changes. The outcome measures were recurrence at final follow-up and wound-related complications like wound gape, scarring and pigmentation. Coming to the results, we had 37 patients with a mean of 51.03 years. Females outnumbered males in our study. We had 92% primary lesions, whereas 3 patients had recurrent lesions following laser. 27 patients, that is 73%, had bilateral lesions. Follow-up ranged from 1 to 60 months, of which 29.7% had more than 24 months follow-up. Coming to the distribution of grading, majority of the patients, that is 75.7%, had grade 1, whereas 8.1% had grade 4 Sankaramenon. Coming to the results, only 1 patient had a recurrence at a 2 years follow-up. She had uncontrolled hyperlipidemia. 2 patients have hypertrophic scar, started on anti-scar creams along with silicone gel sheet. She improved without any surgical interventions. Wound gape happened in 1, which was managed conservatively, and none of the patients had any lid malpositions. Coming to systemic diseases and sandylesma, surprisingly, only 32.4% had hyperlipidemia and 45.9% did not have any systemic associations. So this is one of my patient. She had grade 4 sandylesma. It's a preoperative picture, and this is her picture at final follow-up. So coming to the discussion, this is a unique study which demonstrates the outcome of surgical excision assisted with radiofrequency cautery. So radiofrequency cautery is a high frequency radio waves to cut, coagulate and remove soft tissues. Here what happens is it converts the standard household current to high frequency range, that is 3 to 4 megahertz. That is the frequency of marine band radio used for FM radio transmission. So it is called radiofrequency. So why we should combine surgery as well as radiofrequency cautery? So skin incision here we are done with blade and micro scissors, which reduces the scarring and pigmentary changes. This can have subdermal extension, that is extension to the sandylesma, and radiofrequency ablates the lesions without removing the overlying skin. So the procedure is a single setting, treats both superficial and deep lesions, and in large lesions myocutaneous flaps can be mobilized without causing any eyelid malpositions. So there are various literatures available. Majority are from non-ophthalmic literature. So Lee et al. Noted recurrence of 3.1 and scarring of 4.2 in a cohort of 95 patients. In 2013, a study from India, Anupama Singh et al. Noted recurrence of 4.4% and scarring of nearly 4% in a cohort of 45 patients. But in 2024, in a cohort of 40 patients, they noticed a recurrence of 12.5 and scarring of 15%. So in this they have not utilized radiofrequency. In the other two studies they have utilized radiofrequency. So this is actually in comparison with our studies. So what is the role of lasers? Like there are various lasers available, but the lasers will treat only the superficial lesions and you need multiple sittings. So as per the literature, the lesion clearance rate is only up to 70%, that is 30% lesions are still remaining. You can have pigmentary changes ranging from 7 to 16% and scarring of 0 to 6% with a recurrence of 10 to 21%. However, in surgical, in our series, the complications are much less compared to this lasers. So what this study asks, radiofrequency assisted surgical excision can be an effective method for treating sandylesma with less chances of scarring and depigmentation without causing any lid malpositions. So these are my references. Thank you.
The follow-up is variable, isn't it?
Yeah.
From what does it range?
1 month to 60 months, out of which 29% had more than 24 months follow-up.
But that is very less because outcome measures you cannot mention that. How long have you been having this device, madam?
It's last 12 years. Thank you.
Next is the last presentation of the session. We have Dr. Vinitha Vijayan. She's presenting on morphometric analysis of subretinal hyperreflective material in age-related macular degeneration.
Good afternoon. My topic will be on morphometric analysis of subretinal hyperreflective material in ARMD. So coming on to the introduction, SHRM, as you know, is one of the new few biomarkers in AMD, and this SDOCT feature is identified as a hyperreflective material located between the neurosensory retina and the retinal pigment epithelium. It may consist of fluid, fibrin, blood, scar or fibrovascular tissue, and this composition may change with time with anti-VEGF therapy. So it is important to characterize the SHRM so as to prognosticate the disease and to limit the number of invasive and costly interventions. So coming on to the aim, it is to evaluate the association of morphological features of SHRM with visual acuity in eyes with NAMD and compare it with those patients with, of NAMD without SHRM. It's a retrospective study conducted for a period of 1 year. 100 wet AMD eyes with SHRM was included, 50 eyes without SHRM was included, and all of these were treated with anti-VEGF therapy. The inclusion criteria were patients diagnosed as NAMD with SHRM captured on OCT at baseline visits, patients diagnosed as NAMD without SHRM captured on the OCT at baseline visits, treatment naive status at baseline, 1 year follow-up with BCVA and OCT imaging. The exclusion criteria being poor visibility of SHRM, prior treatment and other ocular conditions. So the image analysis was done. The initial diagnosis of NAMD was made using the spectralis Heidelberg OCT FFA imaging, and the scan pattern was done, included the macular dense scans, and pure quality images were that obscure the SHRM morphology was excluded from the study, and a subgroup analysis of the SHRM was taken, and based on the location of the SHRM at the fovea outside the central 1 millimeter subfield, the dimensions that were included were the height, width, area was measured at baseline, and the changes were recorded at 3 months, 6 months, and 12 months post the anti-VEGF therapy. Coming on to the results, the male to female ratio was 1:1.9, and the mean age was 72.5. The mean BCVA at baseline was 0.68 in eyes with SHRM and 0.46 in eyes without SHRM. At 6 and 12 months, the BCVA did not differ significantly between the patients with SHRM and without SHRM. The mean BCVA at 6 months was 0.5 for eyes with SHRM and 0.35 for eyes without SHRM. The mean BCVA at 12 months was 0.52 logmar for eyes with SHRM and 0.45 logmar for patients without SHRM. So coming on to the location of the SHRM with visual acuity, the presence of SHRM was associated with worse visual acuity at all locations regardless of the height or width when compared to the control groups, and the foveal involvement of SHRM had the worst visual acuity at all groups, the baseline 3 months, 6 months, 12 months when compared to eyes with absence of SHRM in the central 1 millimeter square of the fovea. The SHRM morphology and with visual acuity showed that the hyperreflective SHRM at baseline was found to have the worst baseline and final visual acuity. Well-defined SHRM was associated with poor baseline visual acuity, and presence of IRF was also associated with poor BCVA. A subgroup analysis was done, and based on this, we divided the patients of SHRM based on the height greater than 500 micrometers and less than 500 micrometers. And improvement in vision was seen in both groups from baseline to 12 months post injection, which was however not statistically significant. The SHRM width again was divided into two subgroups, that's greater than 1500 micrometers and less than 1500 meters, and from baseline to 12 months post injection there was improvement in both groups and it was statistically significant. The area again we divided into 0.15 and greater than 0.15 and less than 0.15, and improvement was seen in vision in both groups, and that was statistically significant. Coming on to the discussion. In the CAT analysis, 77% of the eyes showed SHRM at the time of enrollment, with the decrease to 54% after 2 years of treatment. So this current study showed the presence of SHRM in 75.84% treatment-naive eyes with NAMD and persistence of SHRM in 34.3% at the end of the year. Of the baseline OCT parameters, the presence of SHRM, the foveal involvement, larger baseline SHRM dimensions, increased reflectivity, well-defined SHRM borders, SHRM associated with IRF, EZ loss were all associated with worse visual acuity at 1 year after treatment. SHRM a width of greater than 1500 micrometers had the worse visual acuity to a greater extent than the height and area. So the loading dose of anti-VEGF therapy correlated significantly with the decreased SHRM dimensions, and height declined slowly after that. Anti-VEGF therapy decreased, what we postulated is that anti-VEGF therapy decreased the capillary endothelial permeability, thereby reducing the vascular fluid leakage, and this rapid decrease in SHRM thickness would cause the reduction in the fluid component of SHRM induced by anti-VEGF therapy regardless of the drug and regimen. The SHRM anterior and posterior borders were defined, correlated with worst baseline visual acuity and follow-up visual acuity. So coming on to the other studies, Kumar et al. Could not find a significant correlation with the visual acuity and border definitions. Pocrio et al. And Casino collaborated with CAT's analysis, and they also did not find any significant difference. In our study, there was a well-defined SHRM borders were associated with poor visual acuity, and Shafareddin et al. reported the reduction of thickness and volume accompanied an increase in the mean reflectivity following the anti-VEGF therapy. In our study also, the hyperreflectivity was associated with poor visual acuity and was a topographic biomarker for retinal fibrotic scar evolution. So in a nutshell, the positive biomarkers of good visual acuity after the anti-VEGF therapy was hyperreflectivity of SHRM, ill-defined borders, thin SHRM, disappearance of SHRM. Negative were the foveal involvement, hyperreflectivity of SHRM, well-defined SHRM, thick SHRM, greater height, width and area. So SHRM is a surrogate OCT biomarker. Incidence of fibrotic scar formation was higher with hyperreflectivity, and incidence of geographic atrophy was independent of the presence or absence of SHRM. It's a retrospective study, and absence of correlation of multimodal imaging was one of our limitations. Thank you, sir. Yes, sir. Yes. So the negative biomarkers I had mentioned was the foveal involvement of SHRM, then the hyperreflectivity of SHRM, and well-defined SHRM borders, and the increased area, the width and height of SHRM would all result. It would prognosticate that.
No, what are your recommendation for these negative biomarkers? How one should
we have to
treat
probably
them?
intervene more. We have to.
So intervene more in the sense?
Probably switch the anti-VEGF regimen, or we have to increase the frequency of anti-VEGF therapy.
Thank you.
Thus, we have come to the end of the session. Thank you, judges and presenters, for the effort. And I would like to invite Dr. Parthopratim Datta sir to give the memento to Dr. Ganesh V. Raman.